أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان صدق الله العلي العظيم.
Jazakallah. Sadia is also Hafza of Quran Majid. So she's so many attributes.
So we start with our scientific program. Kindly play the video. First of all, we do have couple of videos that is come online, and first video you should play online video. This is Dr. Faisal Aziz. Kindly play his video presentation. Dr. Faisal Aziz. And his presentation is on bloodless tritium oxygen.
Assalamu alaikum everyone. I'm Dr. Faisal Aziz and today I will perform
He's
a
assistant
technique of
professor
bladeless
at
pterygium
BNS
excision
Shifaq Hospital,
on my
Karachi.
personally performed surgery. So let's start. First of all, local anesthetic is injected into the body of the pterygium. Then we grasp the conjunctival fold including the pterygium tissue at the point where the fold is diminishing into the cornea. The conjunctival fold has to be grasped and re-grasped close at its junction into the cornea. One has to be very patient. One cannot hurry, otherwise we will create irregular tags. So piece by piece, bit by bit, the conjunctival fold is grasped. It is pulled upwards and towards the apex of the pterygium and then peeled off from the corneal surface, as you can see. So basically it is a peel off technique, and in which the pterygium tissue is gradually peeled off from the corneal surface. Over here I am doing deep lamellar peeling because near the limbus the pterygium was inserting deeper into the cornea. The remnants of the pterygium tissue are grasped with the tooth forceps and they are removed till we achieve a smooth surface. The purpose is to achieve a smooth corneal surface and at the same time avoiding superficial keratectomy. So at the end, you see the Bowman's layer is not violated, no superficial keratectomy has been performed, and there is a smooth corneal surface. Thank you.
Sir, kindly some comments from this presentation.
If there are any questions, we can take. Otherwise, we'll have discussion at the end.
Dr. Freya, early. Now the second presentation is of Dr. Freya Sherwali. She is working at SIU Hospital at Hyderabad, and her presentation is on ocular myiasis. Can you play her presentation? Patient of orbital tumor. You can see end of the large orbital tumor and the squamous cell carcinoma. after removal, after is presented a lot of maggots in his orbit.
म्यूजिक का जरा कम करें वाला
The live maggots which are present at the tumor excised site involving whole of the orbit. Now this is description of ocular orbital myosis. And should be managed by the turpentine oil. Oil is placed and maggot is removed.
You can see maggots are running away. They know that now they are going to be suffocated.
Then a gauze of soaked turpentine oil has been placed over it, and that is necessary to remove hidden maggots on the corner of the lesion. These are dead now, I think. Postoperative intravenous antibiotic and oral steroid, oral and analgesic has been given with tablet ivermectin. And again, these are supposed to be removed. And after that, you can have a relief person. This is the final picture of this patient. But story doesn't end there. Now it need to be prevented, and they will advise some guidelines. Good work, Dr. Freya.
Freya Sherwali is a very accomplished surgeon, and she was trained at Lahore, Sir Gangaram Hospital, and because her husband is posted at Hyderabad, now she has joined there, and we are very proud that she is now holding the fort of oculoplasty at Hyderabad. So anybody wants to comment regarding the maggots in the orbit? Sir, आपकी आवाज आ जाएगी.
Sometimes it is very difficult to manage these patients because if you've done an exenteration and there is a defect in the bone, these maggots can go into hiding places like in the sinuses and other areas. So that becomes sometimes very difficult to get 100% removal of these maggots, and you might have to do it again and again. At least in one of the patients that I had to manage, she was an old lady and she had these maggots in maxillary sinus and ethmoid sinus, and she had to come a few times to get them completely removed.
ये पीछे दे दें सर, माइक पीछे.
सर अगर टर्पेंटाइन ऑयल अगर अवेलेबल ना हो, जो कि मोस्टली हमें नहीं मिलता समटाइम्स, तो फिर व्हाट आर अदर सॉल्यूशंस व्हिच कैन बी यूज्ड टू रिमूव मैगट्स?
Sir, I would like to add some. It's been easily available at any paint shop.
सर वो तो है लेकिन
It's not.
वो पेन शॉट हॉस्पिटल्स के वो
नहीं, ये है कि वी आर लुकिंग एट द रॉन्ग प्लेसेस। हम भेजते हैं मरीज को कि मेडिकल स्टोर पे चले जाए, ये वहां नहीं मिलेगा, ये हार्डवेयर की शॉप पे मिलेगा।
लेकिन सर
चलें, वो आप इनको लिख दीजिए, मैसेज करें, भेज देंगे, एक कुप्पी भेज देंगे।
sir, I would like to tell
something.
that petroleum jelly we can use.
Okay.
It is easily available, and it also detoxifies and removes the maggots easily.
It's fine. But the advantage of having a liquid is that it can go into the small spaces. But if not available, we can do some. Moreover, we need to do anesthesia as well. Local anesthesia will also immobilize them. Otherwise, they are very fierce. And if you hold and pull and these rupture the body, then there will be more inflammatory and allergic reaction. So we need to remove them completely. और इसके लिए एक वो अरूगाज फोर्सेप्स जो अब हमारे किसी काम की नहीं है सेट में, लेकिन इस काम के लिए बड़ी अच्छी। उबैद आप आगे हैं, आप फ्रंट रो में हैं, सर आप भी आगे हैं।
So next presenter is Dr. Abdul Basit. He is resident at Me Hospital, Lahore, sir. And he is doing a lot of oculoplastic works and now department. Dr. Abdul Basit. His presentation is on external DCR.
Assalamu alaikum. I'm Dr. Abdul Basit and I prepared a small video on
Assalamu
the
alaikum.
technical.
This is Dr. Abdul Basit, PGR I Unit 2, Mio Hospital, Lahore, and I will demonstrate the technique of external DCR under local anesthesia. The external DCR has the advantage of a high success rate, ranging from 90 to 95%. Direct visualization aids in identifying any intra-sac abnormalities. One can form and suture flaps between the lacrimal sac and nasal mucosa, which gives this procedure its high success rate, and all with no need for expensive instrumentation. 1% proparacaine drops are instilled in both eyes, and infratrochlear, transcarancular anterior ethmoidal, and infraarterial nerve blocks are given. A mixture of equal parts 0.5% bupivacaine and 2% lignocaine is used, along with 1:50,000 adrenaline. 1 to 1.5 cc of local is given at each location. The head end is raised about 30 degrees before starting this procedure. Local is also infiltrated in the area of skin incision. The same mixture is used to pack the nasal cavity with a thin sterilized gauze ripper. Good nasal packing ensures painless and bloodless surgery. A 10 mm long straight incision is marked 10 mm from the medial canthus, starting 2 mm above it. A number 15 blade is used to give bone deep straight incision. Dissection is carried out in the subperiosteal plane with a periosteum elevator. The medial canthal tendon is identified and avulsed. Further dissection is done to expose the lacrimal fossa. The suture seeker is used to break the suture. The Carrison bone punch is gently inserted between the bone and nasal mucosa, and the ostium is sequentially enlarged. A bony ostium measuring approximately 15 mm is removed, taking care to avoid a cerebrospinal fluid leak or injuring the underlying nasal mucosa. The osteotomy extends 2 mm above the medial canthal tendon, partially reroofs the NLD inferiorly up to the lamina papyracea posteriorly, and extends 5 to 6 mm anterior to anterior lacrimal crest. Both the puncta are dilated with punctum dilator, and a Bowman probe is used to dent the sac. A number 11 blade is used to incise the sac. The sac should be opened fully with scissors to avoid sump syndrome. Relaxing cuts are then given to fashion anterior and posterior flaps. The posterior flap is excised. A U-shaped, freely rotating nasal mucosal flap is made with a number 11 blade. Intubation of the caniculi is done with the silicone tube. Both ends of the tube are retrieved through the skin incision. A silk suture is used to tie the two silicone tubes at the level of ostium to prevent tube prolapse. The tube is passed through the nasal cavity out the nostril with the help of an artery clip. Nasal and sac interior flaps are sutured to each other using 6-0 vicryl suture. Usually, two sutures are adequate to ensure a good approximation of the flaps. Excessive nasal mucosa can be excised or sutured to the overlying orbicularis oculi muscle. The muscle and skin are closed in two layers using 6-0 vicryl interrupted sutures. This is the first post-op day picture of the patient. I would like to express my heartfelt thanks to Professor Dr. Imran Akram Sahab Sahab for teaching Dr. Salman Hamza, who in turn taught me the art of oculoplasty. Your invaluable contributions have greatly shaped my knowledge and skills. Thank you.
Thank you, Dr. Abdul Basit. For next presentation, I would like to invite Dr. Murtaza Samin from Al Shifa Hospital, Rawalpindi.
Any question from Dr. Abdul Basit? Or we can do at the end discussion.
Bismillahirrahmanirrahim. Good morning to all. And today the topic I have selected to present is endoscopic endonasal DCR with nasal mucosa flap. So what are the advantages of doing this flap is we have to preserve the nasal mucosa so that there are no strictures or granulation or breathing difficulties. So in spite of breaking and tearing the nasal mucosa, we have to save the nasal mucosa while doing the endoscopic endonasal DCR. So this is the U-shaped incision is being given along the axilla of the middle meatus, 8 mm above the axilla, and two vertical incision followed by this horizontal incision with crescent knife, and this incision is up to the middle of the middle turbinate. Then I used to elevate with Fourier periosteum elevator. The flap is being elevated, and this is posterior best flap. Two flaps are being made, posterior best flap and inferior best flap. And U-shaped incision flaps are given and L-shaped are given. I gave U-shaped. So bone is being punched with bone nibbler or bone rongers. The frontal process of the maxillary bone. And here when I asked my assistant to press the sac near the medial canthus from outside, and here you can see clearly the sac is visible. This is the sac, lacrimal sac. You can appreciate this sac. So easy way is to ask your assistant while you are holding the endoscope with one hand and your other hand you are giving the using crescent knife, open sac completely, clear your field, operated field, and while the flap has been created, you have to fold the flap inside the turbinate so that it should not come in your operated field. Sometimes it get dissected along with the bone rongers. Again, I have repeated this step to show that sac has been opened clearly and completely. Multiple attempts you can do because the opening of the sac is very much necessary. Now clear your field, and now this is the step where bicanalular stents or silicone tube is being inserted. The tube is being placed and tied, and now with this periosteum flap elevator, I am repositioning the flap, nasal mucosa flap. You can apply glue, you can stitch the flap, but I don't stitch it or I don't apply glue. I just reposition it and make sure that flap is in proper position. See, you can appreciate all this. Thank you very much. So these are the references of my presentation.
Dr. Paris, are you there? Dr. Paris.
Fine.
Thank you very much. Now I would like to invite Dr. Mohammed Adis he's a professor at Liberating Hospital, Peshawar.
My topic is punctoplasty. Two novel techniques. One is suture-assisted 3-snip punctoplasty, and the other one is canalicular triangular flap punctoplasty. Punctum is stenosed when a 26-gauge lacrimal cannula can't be passed prior to mechanical dilatation. Punctoplasty is the method of treatment for stenosed punctum through various techniques. This is a schematic diagram where we give 3 cuts, one vertical, one horizontal, and then a diagonal. In suture-assisted 3-snip punctoplasty, we use suture. It is the axis to the punctum and helps us in taking a desired, appropriately sized punctoplasty and more chances of success. While in canalicular triangular flap punctoplasty, we make 2 cuts, one vertical and one horizontal. The horizontal is slightly longer than the vertical, and remove the conjunctiva, leaving the mucosa, and we stitch the mucosa with the surrounding conjunctiva. So in this technique, the mucosal flap is preserved and continuity of the lacrimal mucosa with the conjunctiva is provided. This utilized appropriate reepithelialization of the wound edges, resulting in wide punctal opening. So this is my presentation video. This is my hospital, Lady Reading Hospital. No conflict of interest declared. A definition of punctum. First novel technique, suture-assisted 3-snip punctoplasty. Schematic diagram showing 3-snip procedure. First, we give a local anesthesia, then a punctum dilatation, lacrimal probing. Then instead of forceps, we apply suture 7-0 to hold the punctum in position before performing the cuts. So this is a triangular tissue removed with suture attached. Finally, we do a lacrimal syringing. This is the first post-operative picture of the patient. And the second technique, we use a canalicular triangular flap technique. 2 millimeter vertical and 3 millimeter horizontal cuts are made. The conjunctiva is removed, leaving only the lacrimal mucosa. The mucosa is stitched with the surrounding conjunctiva. A few seconds.
Dr. Idris, how long you have followed these patients?
3 to 1 year. 3 months to 1 year because I have started recently.
That's good.
This is the post-op picture.
Because
Thank you.
otherwise, whatever you do, they come back with
Yeah.
shrunken again. Any one want to share the experience of, because this is a big problem. Canaliculus, punctal stenosis. Sir,
Mike, please.
Amir, Avance. Sorry. Amir. आमिर याकूब थोड़ी देर के लिए आवान बन जाए
थोड़ी देर के लिए बन जाते हैं. An excellent technique. I think we should do syringing before we do anything to the punctum to make sure that the nasal lacrimal duct is open.
Yes.
Before we start doing anything to the punctum. Also, I feel that the triangular technique is makes a slightly more wider opening, and that affects the capillarity of the punctum as well. So what I try to do is just remove the posterior wall of the vertical part of the canaliculus. So we make 2 vertical cuts and then a horizontal cut. So you remove just the posterior wall of the vertical part of the canaliculus, 2 millimeters of the vertical part, and you don't make a diagonal cut, and that generally gives you good patency in the long term as well. Also, you need to make sure that there's no conjunctival inflammation before you do this,
Yes.
because a lot of people they have punctal occlusion because of inflammation in the conjunctiva, and if you don't control the inflammation before doing the surgery, the punctum is going to close very quickly.
Yes, sir. Very important.
Next, I
Sir,
would like to.
just one minute.
Next, I would like to invite Professor Khwaja Khala Shoaib Sir, the President of Pakistan Oculoplastic Association, for his presentation.
While his film is being uploaded, you can make your comment. Please, sir.
अच्छा सर इसमें is there any benefit of using the mitomycin C, your experience dilution and to reduce the chances of fibrosis postoperatively during punctoplasty? आपको भी है सर इसमें कोई एक्सपीरियंस कि अगर हम mitomycin C 5-fluorouracil इस्तेमाल करें?
I haven't used it, but it makes it logical. If we can use it in trigium to reduce the healing and recurrence.
Mitomycin C is damaging to the epithelium. So if you use it here, it's likely to cause damage to the epithelium.
5-fluorouracil can be tried.
And more necrosis of the tissues, and which is going to eventually lead to more fibrosis. So I would probably try to avoid this.
माइटोमाइसिन के तो AFIO वाले बड़े खिलाफ हैं. वहाँ इनको परफोरेशन कॉर्निया की केस में हुई, तो इसलिए हम सब अब 5FU पे ज़्यादा शिफ्ट हो रहे हैं. वैसे आप जुनेजो साहब प्लीज, कैली स्पंज फॉर ट्रेबेकुलेक्टमी वो कर सकते हैं आप, मेरा ख्याल कोई हर्ज नहीं, वो भी करें। तो माई इम्प्रेशन इज वॉट एवर यू डू, perhaps it is the repeated punctal dilatation which will enhance its function। लेकिन हमारा मरीज़ आने को तैयार नहीं होता, वो समझते हैं कि डॉक्टर लालची है, बार बार बुला रहा है, वो हमें तो पता है क्या होना है। तो आई डोंट नो, मे बी अगर हमें कोई ऑप्शन ऐसी हो कि एवरी 2 वीक्स हम उसको पंक्टम को डायलेट करते रहें पोस्ट ऑपरेटिव।
सर इसमें देयर विल बी मोर चांसेस दैट फाइब्रोसिस विल अकर, अगर हम मल्टीपल करें तो इसमें हम क्या इंटुबेशन की तरफ जा सकते हैं?
The other way is to put a stent। वो आपकी बात सही है, इसके अंदर मिनी मोनोका अगर कर दें और वो परफोरेटेड भी ट्यूब्स हैं वो भी हम लगा सकते हैं, बट अगेन दे आर हाँ मोनोकैनालिकुलर स्टेंट लगा सकते हैं, कोई भी स्टेंट लगा दें।
डिस्प्ले
बाइकैनालिकुलर तो फिर आप पूरे सिस्टम को डिस्टर्ब कर देंगे, इसलिए प्रॉक्सिमल वाला हाँ वो है। ये एफसीआई की है मेरा ख्याल, हाँ एफसीआई की है, वो कह रहे हैं बाइकैनालिकुलर भी हो सकता है कि दैट विल जस्ट स्टे इन दी प्रॉक्सिमल सिस्टम, वो नीचे नेज़ोलैक्रिमल डक्ट में नहीं जाता, वो यहाँ अवेलेबल भी है।
शुरू से
चलें जी
सर। Bismillahirrahmanirrahim. So I'll be discussing the inferior oblique weakening operations. My name is Khwaja Khalid Shuaib. And the first procedure is myectomy. So in myectomy, we remove 5 to 10 millimeter of inferior oblique. So after isolating the muscle, we introduce two squint hooks and apply the artery forceps. And once we have applied two artery forceps, then we cut the muscle, and after cutting the about 10 millimeter or 5 to 10 millimeter, then we cauterize it. Now cauterization is important because otherwise inferior oblique can bleed and give rise to orbital hematoma. So after cutting the muscle ends, then we allow them to retract back into the tenon space, and we apply the sutures first to the tenon and then to the conjunctival space. So this is in 2 layers we stitch the incision. This incision is 10 to 12 millimeters. So this is hypertropia which has been corrected after myectomy, and this is adduction which has been corrected by the myectomy. The other procedure is the anterior nasal transposition. So in this procedure we move the muscle to the nasal side of the inferior rectus. So this is hypertropia, and this has been corrected by anterior nasal transposition, and this is DVD undercover which has been corrected by the anterior nasal transposition. So what we do is we apply double arm suture 5-0 ethibond, or you can apply the 6-0 vicryl also, and we engage the inferior oblique. Now the advantage of anterior nasal transposition is that you can correct both inferior oblique overaction as well as DVD in the same go. So once the ethibond suture has been passed, then we apply the artery forceps again and cut the muscle and apply cautery. Applying cautery is necessary in all the procedures. So once the inferior oblique has been engaged on sutures, then we clear the space nasal to the inferior rectus, and we stitch the inferior oblique nasal to the inferior rectus, thus causing nasal transposition. So this is the second procedure which we do in this is more effective than myectomy, especially in DVD cases. So then again the tenon and the conjunctiva are closed. So this is the final picture. So the first picture is, so this is the normal course of the inferior oblique, 4 millimeter behind the inferior rectus, and this is the anteriorization, whether behind -2 or anterior +2. The third procedure of the inferior oblique is recession, in which we move the inferior oblique attachment from its normal position to 5 millimeter behind and 2 millimeter temporal to the inferior rectus. Again, the inferior oblique is isolated, hooked, and then so this is the position where we stitch the inferior oblique so that the the action of the inferior oblique decreases. The inferior oblique overaction is eliminated. We have to keep in mind the vortex vein, which can cause severe bleeding. This is another case of anterior nasal transposition, and you have to hook the inferior oblique under direct VN. Blind fishing is not very recommended because it can cause bleeding. So again, the inferior oblique is being hooked on, being sutured, and we. So the last procedure I will show you is myopexy. So this is the anterior nasal transposition, and after taking the inferior oblique on the hook and suture, I have done about 100 cases of inferior oblique overaction, and initially I was doing myectomy and recession more, but now I am doing anterior nasal transposition and myopexy more. So this is an evolving trend. So I would recommend for the beginners to start with the myectomy because it's the simpler procedure and there are less chances of perforation. So this is again, inferior oblique has been brought on the nasal side and stitched there. And the last procedure I will show you, and this is retroequatorial myopexy, in which the inferior oblique is not disinserted, but this is just stitched 8 millimeter behind the inferior rectus insertion. And so this is a simpler procedure, but the limitation is that it is done only in cases of mild to moderate inferior oblique overaction. So thank you very much. Any question, any comment?
Thank you very much. Next.
Next, Dr. Sumaya Ali Khan from AFIU, from Al-Shifa Hospitals.
Just one comment, because inferior oblique insertion is very close to fovea. So we need to be very careful while passing the sutures on. We are also judging these videos. 3 judges are here, Professor Amir, Professor Ibrar, and Professor Khaja Khalid. And all the professors are exempt from the competition. And hopefully we'll give an award. वो निकल गए बाहर.
So Faisal में नाम देना sir.
Assalamu alaikum and good morning. I'm Dr. Sumaya Khan, and I shall be talking about the orbital dermis fat graft. And this is one of the, basically an audit of the procedure that we've done over the past 1.5 years at our center. Slideshow ho raha hai? Excuse me, slideshow ho raha hai? Okay, sorry. So after its popularization by Smith and Petrilli in 1973, the idea was to take the body's own natural reserves of fat and use it to fill the volume of the orbit. So mostly it is taken from the upper outer quadrant of the gluteal area. However, the anterior abdominal wall can also be used. So the idea is that we take a good chunk of fat with the epidermis on top and use it to fill the orbital space. The epidermis is taken off and the dermis and fat are implanted. It provides a good surface for the conformer to sit on as well, and gives a good volume as well. So this is a retrospective case series of about 25 patients enrolled from January 23 to July 24 at our setup. 14 were male and 11 females. The average age was about 31 years, but there were outliers up to 50 years and 2 younger patients as well. All had secondary anophthalmia. Majority had loss of the globe post-trauma, and there were 4 malignancy cases as well. Now, the surgical technique was a standardized technique of taking the dermis fat graft from the gluteal area, plus minus the fornix formation, depending on the degree of volume loss. And they were called for ocularis review and prosthesis fitting at roughly 6 weeks. The advantages are that it is autogenous tissue, so there's no chance of reactivity or reaction, and neither do we have to check for any biocompatibility. The volume and surface is restored. And in children, it is said that it actually grows in the pediatric cases. It becomes vascularized and provides an impetus for the orbital bones to grow as well. And 100% of the patients enrolled in our study had no problem at the donor side later on. The complications are, of course, like any surgery, there's infection, bleeding, and scarring. And in this case, there's also an expected 30%, 30 to 50, according to literature, of fat resorption. There's also a chance of a cyst, because the plane that we create between the epidermis and the dermis, if we leave more of the epidermis behind, there's a chance that the appendages might make a cyst. 2 of the 25 patients had to be relisted because of volume loss. So just a disclaimer that all photos are taken after formal consent. So this is one of our lady patients who had a very shrunken socket. So after inspection and opening of the conjunctiva, we raise the epidermis in a purity orange, employing this technique so that the epidermis is nicely lifted off. By raising blebs injecting local anesthesia. It's stripped off using a blade. Orange appearance, there should be a whitish hue and few hemorrhages. Then we go deeper into the plane to lift off a good chunk of fat. I must say it is a dramatic surgery, because for us ophthalmologists, seeing this much blood is very. We do a horizontal mattress technique to close the donor side. Then it is put into the socket and the dermis is closed with the conjunctiva. Another of our patients who had volume loss, and this is the standard conformer that we use on the first post-op day. He's due for a prosthesis fitting. Another of our patients. So we see that the graft has been uptaken really nicely. The limitations are, of course, that we need a longer follow-up to ascertain the outcome and a larger cohort of patients. And unfortunately, our patients are lost to follow-up once they've started meeting the ocularist. But I must end by saying that quality is never an accident. It is always the result of intelligent effort, and we must persevere. Thank you very much.
Thank you.
Any comments?
It's a very useful technique, especially in Pakistan, where we have got a lot of empty sockets and challenging cases. Professor Zishan from Karachi has published already 100 cases outcome. And Salman Hamza has submitted 46 cases of the orbital socket. आपकी वैसे कितनी सीरीज होगी?
अच्छा ये भी 25 थी?
25. तो I think ये हमारे लिए बड़ी useful technique है. We should all learn it.
Thank you.
Thank you.
Next, Dr. Zulfikar Ali. Is he here? Now I would like to invite Ubaidullah Yassin from AFIU, sir. Top. And his presentation is on medial canthus plication with thermoplasty.
Ladies and gentlemen, Assalamu alaikum. Bismillahirrahmanirrahim. Volume. This lady is suffering. Ladies and gentlemen, Ladies and gentlemen, Assalamu alaikum and very good morning. This lady is suffering from long-standing facial palsy and its ocular complications like ectropion, conjunctival keratinization, punctal aversion and stenosis. Here is marked horizontal lid laxity, especially medial canthal tendon laxity. Now the question is how to manage. Medial canthal tendon laxity leads to lower eyelid laxity and may be associated with entropion or ectropion. If it is not corrected before lid tightening procedure like LTS, excessive lid margin will be resected in an attempt to tighten the lower lid. However, medial canthal tightening is a challenging task. The gold standard technique is to carry out a medial wedge resection, but this sacrifices the lower canaliculus and requires fixation to the posterior lacrimal crest. Medial canthal tendon plication sutures are a simpler alternative, but tend to fail early due to the migration of sutures placed under tension. Here I am demonstrating another simpler yet effective option, originally conceived by a British oculoplastic surgeon, Mr. Thaler. It involves no dissection or resection of the tissues. The technique is simple to perform. It works by creating a strong thermal posterior medial canthal scar by using diathermy. Temporarily absorbable sutures are used to control the direction of healing as demonstrated in this animation. Before embarking on a thermoplasty, it is advisable to rule out medial canthal dehiscence after dilating punctum. Canalicular patency is established by passing Bowman probe. A 5 mm vertical stab incision is made in the skin and orbicularis just lateral to the punctum of lower eyelid. A piece of orbicularis is removed in an attempt to expose the tarsal plate. Here we can see whitish tarsal plate. A Bowman probe is passed into the lower canaliculus till hard stop is achieved. This probe is used as a lever to invert the medial lower eyelid over a cotton bud. Now mark an inverted triangle on the conjunctival surface with the diathermy forceps, whose base extends from the medial canthus to just past the lower punctum. The necrotic surface is scraped off with the knife. A 6-0 double-arm absorbable suture is passed through the firm tissue behind the medial canthus but anterior to the caruncle. Avoid sutures passing through caruncle as sutures will cut through the caruncle. A second similarly placed suture is inserted slightly inferior to the first one. Again, it will be done double-armed. The upper suture needle is now brought through the tarsal plate from posterior to the anterior, lateral to the punctum. The first needle should pass as close to the lid margin as possible to avoid causing an ectropion. And the second suture needle is inserted 1.5 mm below the first one. The second suture needles are similarly inserted through the tarsal plate below the first pair. The sutures are now tightened and tied in the stab wound. As the sutures are tightened, the lower canaliculus becomes kinked. However, it will dissolve as the sutures dissolve spontaneously, by which time a firm scar has formed. The skin is closed by placing two 70 vicral sutures. This is just post-op picture of the lady. However, the patient being operated was different one. This procedure is followed by lateral canthal tightening by doing lateral tarsal strip procedure. Thank you.
Dr. Ubaid is first FCPS orbitanoplastic fellow of College of Physician and Surgeon Pakistan. So he has that honor which nobody can replace him. And now Alhamdulillah we are coming up with other fellows. This year we had 2 successful candidates. So hopefully they'll be coming up in the next conferences. The next one.
Now, the next speaker is Professor Shahid Tarasa from CMH Lahore, and his presentation is orbital fat prolapse. Professor Shahid Tarasa.
Bismillahirrahmanirrahim. First of all, thanks to the organizers for inviting us all and providing us this opportunity to learn from each other. So, this is 60 years old man who presented with swelling in the temporal side of the left eye. You can appreciate this part. So, there is a differential. If temporal side there is some swelling, especially I'm talking about the residents. For consultants, it's very easy to recognize, starting from the lacrimal gland and all the granulomatous inflammation and all that. But once you place local anesthetic and just with the cotton bud, you can push it back, and that is most likely the orbital fat prolapse. Although I have not done imaging of the patient, but if you do imaging, you can see the continuity of the retroorbital fat anteriorly, anterior to the, even this is the basically superior to the insertion of the lateral rectus. So this is same patient from the limbus. The surgery is performed under local anesthesia, and you can see the incision is given 9 to 10 millimeter behind the limbus. This is the area of concern. During surgery, try to be blunt, and whenever there is some, you cut the blood vessels, there should be cautery then and there, okay? Because this retroorbital fat is continuing posteriorly, and if some vessel is ruptured and that keep on bleeding, that can lead to the retrobulbar hemorrhage. And secondly, be very gentle with the tissue, okay? Like nose wale kehte na, boil on the nose should be respected. My message to you is this orbital fat must be respected whenever you are operating the eyelids. So just very gently approach the, first is the conjunctiva, then is the tenon, okay? And bipolar cautery is done continuously wherever is the bleeding point. Now the orbital fat is exposed. You see, this is the anteriorly is the sclera. That is the, because you have approached the most anterior margin of the this prolapsed fat. This is the fat, this is the sclera. separate the tenon from the fat. So at this point, probably there are the two techniques to manage this. One is to reposit it back, and second is to excise it. So I have proceeded for excision, exposure, and then excision. So both have plus and minus points. You see the fat is separated all around from the surrounding tenon. And here is the sclera. Again, be very gentle. And this fat is now exposed. You can see. So the next is to excise it. So RT forceps is applied, keeping in view that all the fat, prolapse fat, is within the artery, because we don't want that some of the blood vessel they remain there and they may bleed retrobulbary. So you can see the tip is visible, and then cut it, and this extra or prolapse fat is excised. And what will be the next step for residents? Like any muscle, you cut it, the cut margins, inferior oblique, like Professor Khalid has shown, you need to cautery, must cauterize completely. You don't want any blood vessel that may bleed later on. Yes. So after that, repair this in two layers. One is tenon and other is the conjunctiva. Tenon from the peripheral part is sutured with 6-0 vicryl to the partially with the sclera, so that the barrier is formed, no further prolapse ahead of that is going on. So that is the first layer, and the second one is the conjunctiva with 8-0 vicryl. Just continue suture. You can repair it. Next. Yes. So this is the after 3-4 days. You can see the conjunctiva is there and fat is the repulsed posteriorly. Now we have created a barrier. So this was the initial picture, then immediate post-op within few days, and this one is the after 2-3 months. You can see now there is no prolapse of the fat. So take home message for residents is that transconjunctival excision is simple, safe and effective primary surgical procedure. Thank you very much.
सर इसमें जो सेकंड एक प्रोसीजर आपने बताया कि वी विल गो फॉर द रिपोजिशन समटाइम्स, तो उसमें फिर सुचर्स कहाँ पे आप इंसर्ट करते हैं सो दैट इट मे नॉट prolapse, reprolapse again?
Yes. So a very good question regarding the second procedure is the you reposit back the prolapse fat. The one is we excised it. Once you are repositing is bad, definitely there is risk, which I think that why to take that risk. Once you are repositing, the blindly there might be small vessels which may rupture. Otherwise, you can go posteriorly, excise it. Once you have exposed the orbital fat, go further posterior where you want to adjust it. Take that sclera superficially, posteriorly, and similarly on the other side sclera, and you stitch it So you can apply the intermittent sutures, interrupted sutures. And after that, again, you apply, repair the conjunctiva as a normal way.
Okay, thank you very much. Next.
Next speaker is for Dr. Foha Ahmed. Dr. Foha Ahmed.
While Foha is taking the rostrum,
Just talk is on orbital cellulitis.
word of caution, while we are operating, we are very close to the lacrimal gland. So the appearance is quite distinct. It's pinkish in color. But the ducts of the lacrimal gland are very close at that point.
So, yes, that is very right. Zahid Kamal, the ducts usually they are opening in the sphere fornix. So, we have given in skin, that is the reason, about 9 millimeter behind the nimbus. That is just below the fornix, so uppermost margin, just to say that opening of the lacrimal gland ducts.
She is resident of Jinnah Hospital, Lahore. And kindly start your presentation, Dr. Foha.
Assalamu alaikum everyone. I'm Dr. Foha Ahmed from Jinnah Hospital, Lahore, and I'm working there as a first year resident. Today, the case that I'm going to present here is the case of orbital cellulitis that leads to fatal intracranial complications. The case that reported to us was 52-year-old male, resident of Okada, headmaster by profession. He presented to us with the protrusion of right eye for 20 days with severe ocular pain, decreased vision and restricted extraocular movements, and high-grade fever. My patient was a normotensive, non-diabetic man. He was experiencing 20-day history of painful right eye. The pain was 7 out of 10 according to the patient. It was throbbing in nature, gradual in onset, and it was associated with high-grade fever, decreased vision, progressive bulging of the eye, and that was leading to the complete ophthalmoplegia over the period of time. The patient has no history of ocular trauma, surgery. He was not using any glasses, no history of ocular medication, intraocular laser or intraocular medication, laser or intraocular injections. The most important here is the history of FES that the patient gave, that he has the FES done 1 month back. As you all know that most of the patients present to the OPD with ENT complications leading to the orbital infections nowadays. The patient was active, non-alcoholic, non-smoker and lower middle class family. We performed the ocular examination. On ocular examination, the visual acuity was PL positive in right eye and the left eye was 6/6. Color vision was altered and in right eye, but it was normal in the left one. Extraocular movements were almost restricted in all gazes. Left eye was complete. The specific examination of proptosis was performed. On inspection, as shown in the picture, there was this huge swelling of upper and lower eyelid with color changes, corneal exposure, and conjunctival exposure. On palpation, the swelling was warm, tense, and tender to touch, but it was non-pulsatile. The poor Bell's phenomenon, proptosis were almost 24 millimeter. There was no palpable mass at the orbital margins. The facial sensations were intact and there was no audible bruit. On slit lamp examination, the conjunctiva of right eye shows the conjunctival congestion, chemosis, hazy cornea, pupils were fixed and mid-dilated with early lenticular changes. The left eye anterior segment was quite healthy with round regular reactive pupils. The posterior segment on fundoscopy shows disc edema and exudative macular detachment on the right side. The left eye fundus was quite healthy and there was no remarkable findings there. So, seeing the patient condition, we admitted the patient to the ward on suspicion of orbital cellulitis. All the baseline investigations were done. CBC, LFT, RFTs, clotting profile, serum electrolyte, blood culture were sent. And we advised the CT orbit with brain. All the empirical antibiotics IV were started and topical tear gels and topical antibiotics were also given. We kept on monitoring the patient orally for visual acuity, color vision, color brightness, appreciation, pupillary reactions, and vital monitoring was ensured. Initially, the patient responded to the antibiotics, but it was a temporary relief from the fever. It later on developed to the contralateral eye having the same symptoms. Normally, initially the patient was non-hypertensive, but the episodes of high blood pressure was noted, and that was managed accordingly. The patient CT brain and orbit came out positive for the orbital cellulitis. During stay, the patient's GCS suddenly dropped. The neurology consult was requested. MRI brain and the CT venogram were advised. The CT venogram showed the superior ophthalmic vein thrombosis. The patient was suddenly shifted to the ICU for the further management, but unfortunately, the patient collapsed at the fourth post-admission day due to the complication. This is a CT venogram that shows the superior ophthalmic vein thrombosis. Okay, this was a rare case of orbital cellulitis that leads to the intracranial complication, because only 3 to 4% of the patients that present with orbital cellulitis goes into intracranial complications like meningitis, brain abscess, or any kind of other complications like cavernous sinus thrombosis. The purpose of discussing this topic today in this meeting was to emphasize the importance of early presentation of the patient through the hospital, timely diagnosis, and multidisciplinary approach for the effective management to decrease the mortality rate of such patients. Thank you so much.
Thank you very much. Next, I would like to invite Dr. Farah Huma. Yes, Dr. Paris. And her presentation is on optic nerve sheath fenestration.
Dr. Paras is presenting for Dr. Farah Huma. She is senior registrar at Allied Hospital, Faisalabad. She was trained at Mayo Hospital, and now she is practicing oculoplastic over there.
Assalamu alaikum, respected seniors and colleagues. I am Dr. Paras, working as Senior Registrar in Avicenna Medical College. I am presenting on behalf of Dr. Farah Huma, who is my worthy senior. We came across a case of 20-year-old female unmarried staff nurse who presented to firstly the neurology department with complaint of blurred vision and headache for 1 week. The pain was dull in character, more in early morning, and it was not relieved by medication. The visual acuity in the right eye was perception of light, and left eye was counting finger at 2 feet on presentation. Color vision was affected. The pupillary reactions were normal. Upon lumbar puncture, we found out that the CSF pressure was 85 centimeters of water, and the physical, chemical, and microscopic examination was within normal limits. Lumbar therapeutic puncture was done twice, and CSF pressure was decreased to 42 centimeters of water, and final diagnosis of idiopathic intracranial hypertension was made, and the patient was referred to the ophthalmology department. So we performed treatment of the patient by optic nerve sheath fenestration. It is an effective procedure for treatment of vision loss in idiopathic intracranial hypertension, and results in decreased papilledema in both the ipsilateral and the contralateral eye. So firstly, what has been done is that eye has been opened maximally with the speculum, and limited peritomy has been done superiorly, inferiorly, and medially. And with the help of malleable retractors, a space has been created with the eyeball pushed laterally, and medially there is the wall of the orbit. And the medial rectus muscle has been disinserted and secured with vicryl sutures and pushed medially in order to create a space, has been pushed laterally in order to create a space where we can isolate the optic nerve. So here we can see that the optic nerve is visible, and with the help of cotton tip applicators it will be cleaned, and the vessels on it will be swiped away. With the help of a 15-degree keratome, an incision is going to be made 1 millimeter posterior to the insertion of the optic nerve. Here a window is being created by cutting off a piece of the dural sheath, and the incision leads to a gush of the CSF, which shows us a successful opening of the subarachnoid space. At the end, the medial rectus muscle is going to be reinserted and conjunctiva will be closed with vicryl suturing. Optic nerve sheath fenestration is indicated in vision loss in idiopathic intracranial hypertension, traumatic optic nerve sheath hemorrhage, and chronic papilledema secondary to non-resectable CNS masses. The procedure I have described in the video. This is a post-op picture of the patient taken after her consent. And these are the fundus photographs, and the post-op visual acuity was 6/24 in both eyes after keeping her for 3 days under observation in our ward. The contrast sensitivity, color vision, visual fields were decreased at the time of discharge. Complications of this procedure can be diplopia, sudden vision loss, orbital hemorrhage, intrasheath hemorrhage, and pupillary abnormalities. Thank you very much.
Thank you.
Thank you very much. Now I would like to invite Professor Abrar Hussain Sahab for his presentation of post-auricular skin graft, how to take it, and he is immediate ex-president of Pakistan Oculoplastic Association. Professor Abrar Sahab.
Regarding optic nerve sheath fenestration, it is a very useful procedure, but unfortunately because neurosurgeons work more closely to the neurophysicians, so most of the cases are referred to them. Otherwise, it is very safe and less traumatic. They put a shunt, which is ventriculoperitoneal shunt, and it is a lifetime misery for the patient.
For this purpose, I use a sterilized paper. So one thing about this optic nerve fenestration, आपके रहते हैं कैली sponge, that can also be used. Assalamu alaikum, Professor Abrar Hussain here from Pakistan. Today I'm going to share with you the surgical technique of taking retroauricular or post-auricular full thickness skin graft. Because I use a sterilized paper, usually paper cover of the gloves. The paper is applied.
There is also a slight difference. If the headaches are more, then ventriculoperitoneal shunt is advised. And if the visual field loss is more, then optic nerve sheath fenestration is more preferred.
Assalamu alaikum, Professor Abrar Hussain here from Pakistan. Today I'm going to share with you the surgical technique of taking
there's some problem in the video
retroauricular.
present. Now I would like to invite Professor Zahid Kamal Siddiqui Sahab, the chairman of this session. He is currently principal of Rehbar Medical College. Sir, and he's also the chairman of scientific committee of oculoplasty, the Lahore Ophthalmo, and he's been the man who's supported and he's like arranged all the stuff for you.
Thank you very much. Um, he's been very generous in praising, but he himself worked very hard for this program, and obviously all the oculoplastic association
Assalamu
team.
alaikum, Professor Brown. Where craft is important.
This child presented to us when I joined PRTH, and she had large mass, and she was being treated as orbital cellulitis. So I said, no, it's something else. So we removed the mass. And send it for histological examination. It was very anterior, fortunately not going much. Rhabdomyosarcoma came out.
ना 2 माह पहले ना इसकी राइट आई पे ना विशुद्धि शो हुई जो आस्ता आस्ता बढ़ रही थी। इसका हमने सीटी स्कैन वगैरह करवाया सियालकोट से, तो उन्होंने 3 माह के बाद बताया था ऑपरेट होगा, लेकिन ये लगातार बढ़ती जा रही थी। इस वजह से हम काफ़ी परेशान थे। फिर हम PRTH में आए और इधर अच्छे तरीके से हमारा इलाज मुआवजा हुआ।
Look at what you can offer as oculoplastics.
और हमें किसी किस्म की कोई परेशानी नहीं बनी।
The parents are so much worried when they come to you. You can see the smile on this child's face. There is a little bit of interesting fact that the initial biopsy came out to be dermatofibroma. So we were very surprised that it cannot be that, but fortunately after resection, complete resection, it was confirmed that it was rhabdomyosarcoma. Fortunately it did not metastasize, so we sent it to oncology department of Children's Hospital, and she is now fully recovered. Any comments or questions regarding rhabdomyosarcoma? Because they progress very fast. But the good news is that the orbital rhabdomyosarcomas in children, they've got very good response. Yes, sir.
How long was the history?
3 months.
3 months.
इधर से शादी माइक दे दें और ये जरा अपनी टीम को चाय शाय पिलाएं, बड़ी स्लोली चल रहे हैं.
Assalamualaikum. I'm Dr. Sadia from Mayo Hospital. Actually, we encounter such patients very commonly, rhabdo. And here I want to request all the oculoplastic and the orbital surgeons that we should make some Pakistan guidelines to treat these rhabdo cases, because there come a very delay in these patients. When they come to us, it's already 1 to 2 months and the tumor has spread to the other eye or to the intracranial extension. If we can go for early incinal biopsy, if it is not possible for, because if the neuroimaging is not done and it takes time of about 1 to 2 months. So if we can do the incinal biopsy early in these cases, or should we wait for the neuroimaging to be done and then we should proceed for these cases?
So, Dr. Sadia.
Thank you. Achha, I have a collection of about 15 cases of this rhabdomyosarcoma. You are right that they are very progressing very rapidly. There are, you said, some guidelines. There are some international guidelines. So grade 1, 2, 3, and 4. So we should, I think we should follow that guideline. This tumor is not that common. I don't know here what about here, but in 5-6 years I have collected only these 12 or 15 cases. But here I don't know. They are too much.
difficult to remove in toto.
You are very right, sir. Can you come for your presentation?
Okay, thank you.
But meanwhile, I would just quote to another patient who was treated in 3 different hospitals of Punjab with diagnosis of orbital cellulitis. And perhaps he spent 500,000 rupees before coming to us when the management of orbital rhabdomyosarcoma was done. So perhaps we need to give more instruction and presentations at the pediatric conference. We know about it, but the pediatricians do not have at back of their mind because it is a fast progressing tumor. So they always start treating it as orbital cellulitis. Sir.
Thank you. Bismillah ar-Rahman ar-Rahim. So the sound is there in the video.
Alaikum, Professor Brorson here from Pakistan. Today I'm going to share with you the surgical technique of taking retroauricular or post-auricular full thickness skin graft. This skin is best matching skin for use around the eye when needed. Moreover, this area is hidden behind the pin of the ear, hence scar is not visible. First step is to take template of shape and size of the graft. For this purpose, I use a sterilized paper, usually paper cover of the gloves. The paper is applied over the area where graft is to be put. This forms print of that area over the paper. The paper is cut about 1 millimeter outside the imprint. This makes the template of the graft. In the second step, the area behind the ear is marked. For this, the assistant holds the ear folded forward and retroauricular skin exposed. The template is put over the skin and marker is used to mark the area around the template. In third step, I give local anesthesia to the marked area. For this purpose, I inject 1 to 2 ml mixture of 2% xylocaine with 1 into 200,000 international units of adrenaline. Next step is to take full thickness skin graft. For this purpose, I use number 15 blade and give skin deep incision over the mark. Then skin is elevated from one end using Westcott scissor and continued to be separated towards the other end. This dissection should remain skin deep over the superficial temporal fascia because posterior auricular artery and muscle are very close in the fascia. Moreover, while giving incision in the skin, the scalpel should be held in a controlled manner, especially inferiorly towards the neck, because external carotid artery is not that far away. Slowly and gradually, the skin graft is separated from the underlying fascia till it is totally separated. The graft is put in a tray with normal saline in it. Next step is to repair the gap from where graft has been taken. For this purpose, I use 4O silk. My first suture is a mattress suture in the middle of the graft. Rest of the sutures are simple interrupted sutures till the gap is closed. Finally, the skin graft is used to cover the gap over or around the eyelids where needed.
First, stay sutures are applied to hold the graft, and then it is sutured to the surrounding skin all around.
Thanks for watching this video.
Thank you, Professor Abrar. Yeah, we come to end of this session. Professor Abrar was the one who started the video oculoplastic sessions as president of the POA, and now it has really taken off. And you can see that right from first year resident to senior professors like to present at this forum, and I hope more and more of you would like to come up. Perhaps for future, Salman, we should try to get more of the video rather than the slide presentation, because it takes more time. And I congratulate Professor Brar because he's got a very good YouTube channel on which he maintains small steps, baby steps. When you, as a beginner, are going to start, then you need help if your supervisor is not there.
I care with the Braro. The channel is I care with the Braro Sen.
हाँ, ये सर का लैपटॉप दे दें ताकि, लेकिन जब आप प्रोफेसर इब्रार का चैनल पे जाएं तो घंटी का बटन दबाना ना भूलें. Okay, ladies and gentlemen, we are going to start the next session in few minutes. Professor, that would be an orbital session. So kindly stay around. Meanwhile, we can have a group photo of all the oculoplastic team. Sir, if we can keep sitting जहाँ आप हैं और कुछ लोग पीछे आ जाएं, तो फर्स्ट रो में सीनियर बैठ जाएं. प्लीज आप लोग आगे आ जाएं जहाँ खड़े.
Sir, I do have a couple of announcements. One is that if somebody is interested to get CME hours, then he can contact the facilitator for it. It will they will be given a form and that you are supposed to fill and get CME hours for this session. And we do have 3 symposia. This is number 1 symposia today, and 2 symposia at 11, and second is at 3:30. While we do have 2 instruction courses today, one is at 2 p.m. and other is about 4 p.m. I think so. 3 p.m. And the second one is too important. Everyone is supposed to be here. Is Professor Miran Akram Saab sir.
2 o'clock we have got
instruction course. Sir.
Instruction course on. Okay. So kindly join us. We have the judges are making the result for the video symposium. That would be announced at the gala dinner, and inshallah, presidents, ex-presidents and current presidents will award the winner.